Hello, everyone. I'm Sherry with the CGH Health Foundation, and welcome to our Growing Healthier program. This is an educational series that's sponsored by the CGH Health Foundation. All of our Growing Healthier programs are presented here on Facebook Live at 12 noon on the designated Thursday. And if you miss one, don't worry about it. You can find it on our YouTube channel. Or go to the CGH website and look for our YouTube YouTube and radio interviews. In our Growing Healthier programs, we try to present topics and educate you about important health issues. And it gives us a chance to introduce you to some of our great providers. And we have another one of our great providers here with us today, and that's Dr. Jason Reeder. And Dr. Reeder is one of our family medicine providers. He's also the medical director for the Rock River Hospice and Home. And since November is National Hospice and Palliative Care Month, Dr. Bird's going to be talking to him about hospice and palliative care and what the differences are and everything that you want to know about that topic. We do not have a Facebook Live program scheduled for December, but we are working on our 2024 programs. And the first of those is going to be presented on January 11th. And Dr. Lucky, another one of our great family medicine providers, will be here talking to Dr. Bird about shingles and other rashes. So put that one on your calendar and look for us on January 11th at noon here on Facebook Live. And with that being said, I'll turn it back over to Dr. Bird.
Thank you, Sherry. Appreciate the lead in. And so, yeah, looking forward to, we're going to talk with, by the way, I'm Bill Bird, Chief Medical Officer here at CGH Medical Center. Thanks for watching our interview today. So without further ado, let's get Dr. Reeder on the video. Hi, Dr. Reeder.
Hi, Dr. Bird.
Great to have you again here on Facebook Live. Dr. Reeder, he's a regular. We get him at least about once a year. It seems like we'll pull him in to talk a little bit. So just full disclosure for folks who are watching, we've had this interview before, Dr. Reeder and I, about palliative hospice and palliative care. But I don't just think, I know it's important that we continue to have these conversations because different people now versus a year ago, when we had this interview, might be in the situation where either they or their family members are having conversations or thinking about palliative care or hospice care, or may need to know about what those mean. And so I that's why we're doing this interview again. We don't typically retread things, but it's just an important enough topic and doesn't get talked about enough that's why we're doing it again. So thanks Jay because Jay is a very much an expert on this topic, having done this for how many years have you been involved in hospice and palliative care, Jay?
I've been the medical director since 2003, so 20 years.
Oh wow. Okay. All right.
And I like to say that I'm second generation hospice because my dad was a hospice medical director in his where he practiced down in Canton for about 20 years as well.
Okay. So you have 40 years in the family.
40 years in the family.
You made that clear to your children that there's an expectation for continuing that legacy?
No, I try not to meddle too much in what they're doing in the future.
Yeah. All right. Well, let's get at it. Let's go through a few questions here.
Sure.
So just how would you define palliative care versus hospice care, Jay?
Yeah, it's a good question. There's a lot of talk about palliative care and hospice, and they're so closely linked, right? Palliative care, at its most broad definition, is any treatment of pain or distress. And the most basic, taking a Tylenol is palliative for a headache. Putting a Band-Aid on your child's open wound is a palliative care for that treatment, for that problem. But I think where it's more used nowadays are people with complicated medical problems. They bring in palliative care teams. And usually that should be through your primary care provider or your specialist that you're working with. It's for people who have, whether it's complicated cancer care, but it can also be severe heart disease, COPD. And the difference with hospice is it is end of life care. And by definition, hospice patients are patients with a serious condition who have a life expectancy less than 6 months, who family have decided, family and patients together, hopefully with their hospital, their doctor team, have decided they don't want any further treatment. Further treatment is futile, and then we're focusing on quality of life. So hospice care is still palliative care because we're still very much focused on quality of life and controlling pain and all the needs of the family. But hospice is in the step of care where we expect there to have less than a 6-month prognosis, and aggressive treatments are no longer desired.
Yeah, makes sense. Is there a time frame for palliative care?
Not really, and I'm not being invasive about that, but it's not really well defined. I think it's used most often in people who are getting actively treated for cancer diagnosis. Our cancer teams really like to have a palliative care approach and teams that are making sure that all of their needs and the family needs are met, and what that might be with dealing with the cost of medications, dealing with pain, dealing with the kind of psychological trauma for family and patients when they're dealing these diagnoses. But in a perfect world, that's kind of done in conjunction with the treating specialist and the primary care. And, you and I, Bill, are family practice doctors, so I always am a big proponent for having your primary care being a huge part of this. But it doesn't have to be, honestly. It can be done well through the specialty team.
Yeah, for sure. And so, at times these words that we're using, palliative care and particularly hospice care, can have had some negative connotations. So folks kind of hear that and go, oh my goodness.
Yeah.
So I know that there must be times when you have conversations with patients and families where there's resistance to either palliative or hospice care.
Yeah.
Are there any themes in terms of the resistance, and how do you have conversations or navigate those or help folks to understand the value of these services?
Well, especially with hospice care, one, I think transparency is really important. Thankfully, I haven't seen this in a long time, but I remember in training and even some of the first years of me starting working here, family members saying things like, we're not telling grandma she has cancer. And we're like, we're definitely telling grandma she has cancer. I mean, it's not, it's a shared decision. But also focusing on patients, what their desires are, what they want and what the family wants. I think the best way to talk about hospice is it's not we're giving up. It's we've got a battle we can't win, so we're going to make the best of the time that we have. It doesn't mean again, a terrible example is people thinking that, oh, we're just putting someone on a morphine drip or and forgetting about them. No, we have patients who are on hospice care who still are active in the community. They have a diagnosis, but they're still able to go visit family. I mean, some people that they like to go to the casinos, they're still going to the casino. It's very individualized to the person and where they are in their journey. So our hospice team is there to make sure all the resources are in place. And we do hospice. What I often say is we do hospice where patients need it. For most of the duration of hospice and hospice care, it's always been in the home, but we also do hospice care and in the hospice and palliative care in the hospital. We do hospice care in nursing homes, and now in our community, we have the advantage of doing inpatient hospice care for people that are having crisis and can't be where maybe they want to be, but we have somewhere else for them to go. If there's a crisis, we can be in our inpatient hospice home.
Yeah. You talked about someone who has like a cancer diagnosis, and so at some point in time they decide they want to go the hospice route. I think a lot of times folks don't think of other problems as potentially being something that would be a fit for hospice. Can you talk about those a little bit?
Yeah, no, thank you for asking. We have patients who are hospice diagnoses who have strokes, severe end-stage heart disease, where they keep getting readmitted to the hospital and the aggressive treatments aren't working. I mean, our heart doctors and our neurologists and our hospitalists, they kind of recognize as well that, aggressive treatment isn't working. And I think sometimes families may be surprised that their cardiologist or their neurologist, their hospitalist, or even their primary care doctor is saying with those diagnoses, hospice is an option since things are not getting better and they keep getting worse. And often it's also the direction from the patients who are like, I'm really tired of driving back and forth to the hospital, or I don't want to go to the hospital anymore. And so then the conversation comes in. Other diagnosis, end stage dementia. When dementia progresses, whether that's Alzheimer's or vascular dementia, people's thirst and hunger mechanism starts getting shut down, and their swallowing mechanism starts to get shut down. And we often see people that are just sort of with dementia that are sort of fading, literally kind of fading away, losing weight. They're not eating. And it becomes obvious that they're really declining. Those are good hospice. And we have many patients in hospice for that. We sometimes call them protein calorie malnutrition because they're not even meeting their basic needs for nutrition, and they're getting weaker and they're falling down and they're sleeping more. So those are other triggers that, again, I remember as a student, or I guess I was a resident when I was in training. I had my first dementia patient that was declining so much. I had to ask my attending, wait a minute, they're really declining, losing weight. Can I admit somebody to hospice for just this? And they were, correctly said, oh yeah, absolutely. I still kind of remember that distinctly. But those are another, we even sometimes have people who are on end stage emphysema who are tired of getting admitted back and forth to the hospital. Again, are often losing weight from the work of breathing so much and can't get around the house. Those are other diagnoses.
Yeah.
And at this time, when we talk about all these different diagnoses, when you're in hospice care, sometimes people are admitted after an acute stroke or acute heart attack. We're always kind of reevaluating how they're doing for these other kind of non-cancer diagnoses, because every once in a while someone will come to our hospice service and they'll get better. And we have to kind of reassess and go,
right.
You know what, you are doing well, or if we're talking to the family, your loved one is now doing much better than expected. And
right.
we kind of have to reassess. And then sometimes we even kind of put them on standby. We're like, well, you don't really need hospice care anymore, and we're going to send you back to your regular doctor. We'll be here, and if you need us, and we may come back again. But that is also kind of another unexpected outcome. And I know that is a big frustration with patients when you get a prognosis from a physician, and then from no fault of your own, you do better.
Yeah. Right.
And so that's kind of another reality of hospice, that we try to tell people that even up front, that there's a chance if someone gets better that we may discharge them from hospice. And I think the majority of the time when people are at that diagnosis, that doesn't happen. And then we just continue to do focus on quality of life through the rest of their life and being a support for family. But that's a very real problem or scenario that we have in hospice care as well.
Let me spin the question one other way in terms of these patients that qualify for hospice. Because you review these, like in your role as a medical director, you review to see does that make sense for someone to be hospice?
Yeah.
Are there any particular situations or conditions where you tend to say, no, I don't think this is a good fit?
Honestly, some of those ones that we just talked about with there are certain with dementia patients who, they're definitely declining, but they're not losing weight, and they're still doing some things for themselves. And unfortunately, the difficult part with dementia is some patients will have such a huge decline, but continue to live for many years, despite tragically not remembering family members or being really a shell of who they are. But they don't always reach, but they're not to the point where they're having a prognosis less than 6 months, and that is something we have to reassess. And again, heart failure, COPD, even strokes, we sometimes see people make an unexpected recovery. We've even had people that come in with a diagnosis of renal failure, and the doctors had expected them to require dialysis, and the patient and families did not want to do that, and then their kidney function starts getting better on its own, and we have to kind of reassess. So those are reasons why. So again, those are reasons why people might go on and off hospice. To your question, when I look at the charts, sometimes I will just say, the patient honestly doesn't look like they meet criteria yet. Every patient who gets consulted with hospice, if we look at their case and interview the patient and the family and the records, and we say they don't qualify, we always tell them, but we'll reassess again in 2 weeks, and usually 2 weeks again after that. So we don't just slam the door on them.
That makes sense.
Open, and with every expectation for the family or their doctors to call us back if the patient declines again. And
that makes sense. Yeah. So let's then go down the path of, okay, patient wants to do hospice. You've reviewed the case. The doctor who's taking care of the patient, if it's not you, has reviewed the case, signed off. Yep, this is a hospice patient. Particularly for hospice, but also let's say for palliative care as well. What does that mean in terms of the services that will be provided to the patient as well as their family?
Well, palliative care, let me start with palliative care first, because palliative care is sort of a newer term in healthcare, and it doesn't have as much services available that are covered by insurances or Medicare. But it usually means in palliative care having resources of a social worker through either the hospital or through the clinic and doctors that you're working with, but also some component of home nursing, other people that can check on both the family and the patient to make sure that their needs, their pain needs, their emotional needs are met, and other resources in the home, like, simple wheelchairs and canes, home IVs, those things that need to be done. Hospice has a little bit more defined role in that once you enter hospice, you kind of get the whole package of everything, which means we've got social workers, the home health aides that come in. It's not 24-hour-a-day service. I mean, it doesn't mean you're going to have a 24-hour hospice worker there with you, but you will have someone on call if your loved one's at home, who, if there's an emergency, you can call them, and the nurses may come out that night. But they have aides who help with bathing and care around the home for them, that come in a couple times a week, sometimes more often, depending on the patient or the needs. And we get in hospital beds if it's needed, again, trying to assess everything that they might need. And then in addition to, we've got our bereavement coordinators that help the family. We always have emotional and faith needs. We try to make sure people are connected with their clergy of choice. We do have a hospice chaplain as well, which the hospice has, the hospital has a chaplain as well too. But all of those services kind of fall under the umbrella of hospice. I know it's a lot, and we do a lot of kind of teaching when people come on board about what our services are. And sometimes it's almost overwhelming, like, who are you again? Because they're meeting with the next person. This is the nurse, this is the home health aide, this is the social worker. This is the volunteer coordinator, because sometimes volunteers can come in and help out a little bit too. So that's a long answer because it is a lot, and I try to make it, but we try to make it as easy as possible. And sometimes those admissions can take a long time when we talk about everything that's needed.
So when we talk about what hospice doesn't provide,
sure,
it sounds like my experience of this is it tends to be that it's still not a 24/7 situation, at least if you're in a home.
Yes.
And yet, if you're in those situations where there's just not a good fit to be in a home, there's a hospice house here in this community and other communities like ours.
Yes.
And also you can go to a nursing facility. And so then all of a sudden you have the 24/7. And is that kind of the progression in terms of levels of hospice?
I mean, yes and no. I mean, some of our patients may have been living in a nursing home for a while and then become hospice eligible. People that have been independent in the home, that can be a progression. And again, there are some people that have family resources where they may be able to either provide 24/7 care or have in-home care that they pay for, that's sort of private duty nursing that is providing more 24-hour care.
Okay.
Again, that's another added expense to the family. And again, not all families can do that because of work and where their financial situation is. But we try to coordinate all of this. And again, our goal is always to give hospice where patients, hospice care where patients need it, you know, and if we can do it at home, that's always the goal. The hospice house here in Sterling, it has, you know, we have 6 beds. It's beautiful. We can't fit more than that. And some days we have, they're not all full, and some days they are all full. But we use it more for crisis for patients that are struggling in whatever environment they are. And there are some times where people come to the hospice house in some kind of crisis, with a pain crisis or a caregiver crisis, where there's not someone there to take care of them. And we kind of stabilize things and get them to the point where maybe they return back to where they were before. Okay. So I know that's a lot of different scenarios, but we try to, again, individualize the care for each patient and their family.
Yeah. It sounds like it's not a one size fits all kind of situation.
No, it's not. And no, you know, in every case, every case is unique.
Yeah. You know, I guess the final question is that I mean, obviously I have nursing home patients, so I know this whole hospice thing in nursing home quite a bit, and patients over the years that have had hospice, and it's so helpful for patients and their families. I'm sure you have hundreds of stories of how hospice has been helpful for patients. Do you want to just kind of talk about that a little bit, Jay?
Well, you know, we do. It's hard to pick one, you know, but we do get a lot of because the cases are so different. You know, we get a lot of positive feedback from coming into the patient's home and respecting their wishes for being there, taking care of them at home. And because some people have very strong desires that they want to stay and even, you know, die in their home, and we make that happen as easy as possible. We've had other times where patients were out of town and became a hospice patient at an out-of-town hospital, and family was super grateful that we could take them back into either their home or into our hospice house and have a calm place. You know, we even do care for young people. We you know, who have terminal illnesses, that we can provide care here in our hospice house. And again, we get a lot of compliments for that. So I'm kind of punting and not giving you one situation, because there's so many. But it is just having the resources to talk about the illness and being there for the family, being there for the patient to make their quality of life as good as we can for as long as we can. And that's what it's about. And I didn't answer that as maybe as well as I should, but I
get it. You know, I think the main theme I wanted us just to bring forth to folks is that, like, as clinicians, the experience that the families and patients have of hospice, in my experience, and I'm pretty sure in yours as well, has been overwhelmingly positive.
Yeah.
In terms of, once that is in place for the patient as well as for the family.
Yeah, absolutely. And again, we're kind of experts in end of life care, and this is the place where you go where we're not afraid of talking about death and dying, which so many people are. Still such a taboo. But like this is where we are. We need to be realistic about it. And I always want to treat people like I would want to be treated, like my family would want to be treated, and it is it becomes a very close relationship with families because, again, we're often in their own homes, and so it has to be.
Yeah, good. Well, good. Thanks, Danielle. Appreciate that. You always said I'm your favorite, Danielle. Now I'm feeling like like there's something going on here. Thanks, Abby. Appreciate it.
Sure.
So one other thing, just a caveat. Okay, let's see. Would they continue? You want to answer that one, Jay?
Yeah, and when you talk about services that are covered and services that are not covered, sometimes some of the medications, if they're not for the hospice diagnosis, are not always covered by hospice. But if someone is on thyroid medication or heart medications, it's very individualized. Like usually I'll tell them, you know what, we really don't need to keep taking your cholesterol medicine anymore. We'll watch your blood pressure because often at end of life, people's blood pressure starts dropping. And sometimes they even lose the ability to swallow. And then we're not, trying to force medications on people. So now at the same time, I have some people who are like, I am taking my multivitamin as long as I can because I've taken it for years and I'm not changing. Right. And then we're like, okay,
Yeah, right. Yeah, good. Sorry.
That is okay. But I will often say, like, you don't have to keep taking that multivitamin, and you don't need to keep taking that cholesterol medicine, and you might need a less or none of some of these diabetes medications because end of life care, we're not as concerned about slightly higher blood sugars, and we really are more worried about making someone feel terrible with a low blood sugar from some of the medicines. Yeah. So we do kind of look at all of the medications, and honestly, I'm frequently saying, "Why are we still taking that? Why are we still asking them to take that?"
Yeah.
So yeah, it's a good question.
Yeah, and a good answer.
Yeah.
I was just thinking one disclaimer I wanted to make before we finish. So Dr. Reeder is, like myself, a CGH employee that sees patients for CGH. He does this medical director thing for the Rock River Hospice Valley. It's an extra thing that he does, and I know he's very much appreciates the work that organization does. But I just want to make sure that folks understand that there are other hospice places. I'm not condoning any particular hospice place in this conversation. It's just I happen to know Jay, and he is very knowledgeable on this, and
right.
So there's other places that provide hospice care in our area that for folks to be aware of.
Yeah, and working as a family practice doctor in the community, I worked with most of the hospice organizations in the area, and I've worked well with them. Honestly, I'm just obviously most familiar with and proud of
right.
of Rock River Hospice and Home.
Yeah. Good. Well, Jay, I think can you stick around? I wanted to show a few slides, but since you know everyone around here pretty well, I thought I'd let you kind of make a few comments.
I will stick around. I will be remiss to say I wore my Christmassy tie today because Rock River Hospice and hospice awareness starts with their festival of trees at the mall today.
Ah, there you go. Let's hold it up a little better for us. Can you come a little closer to the camera?
Oh, of course.
I'm seeing your neck.
Oh, my tie.
Your tie, yeah. Ooh, okay.
It's just a big ornamenting tie.
Oh, nice. Very nice.
I didn't have like a great tree tie because
I should have done the bow tie thing with some sort of festive thing. I just didn't get there today. It's our turkey handout day at the hospital. I should have had like some sort of turkeys or something on there.
Right, or a pilgrim hat would have been great. But anyway,
next year when we do this.
At the store, though, they're having the country store that has a lot of like Christmas decorations. They've got all these cookies that this army of bakers have that do every year, and not just today, it goes all through this weekend, next week until next Sunday. So if you're at the mall, you can walk around and look at the trees, and they have good information about hospice out there too. So if you're looking for more hospice information, that's part of the Festival of Trees as well. And yes, it's a fundraiser, but it's also about hospice awareness.
Very good.
Sorry.
Okay, Rebecca, let's tee them up. I want to Employee of the Month, Kathy. I want to congratulate and say thanks to Kathy for all the work she does for the little people that she takes care of over at our Helping Hands Daycare. And Karen works in the emergency department. Happy Daisy Award winner to Karen. You know Karen, don't you, Jay?
I know her very well. Yeah, she's worked at the hospital for, it seems like, as long as I have.
But she hasn't.
But she hasn't.
I don't think so.
No, not as long as
she's
me.
A young woman, Jay.
She was in the peds. She was on the peds floor for many years. I knew her. Right. I think I knew her first there, but she's been in the ER for a long time. Great.
All right. Let's see. Candace, you know Candace when you were around on the medical floor, right?
Absolutely. I've seen her this week while I've been working on the medical floor, and I'm happy she got recognized.
Yeah. Congratulations to her. What do you want to say about Patty?
Patty Nice has definitely, she's worked longer than me, 46 years. What's the exact time?
We heard before we started, 46 years, 5 months, and 10 days is how long she worked for us.
Wow. No, Patty is a tireless CCU nurse who's been a great resource for our hospital for so many. I have only known her to work in the CCU. I don't know.
That's correct. That's it. That's all she ever did. I mean, not all she ever. I mean, that's incredible to work in a CCU for 46 years, 5 months, and 10 days.
Yeah, and through the pandemic was such a hard time for us in the CCU, wonderful.
We wish Patty nothing but the best. And so, yes, we're speaking of things going on. We have an event here where we light up the place. So next Tuesday, when you start driving by the hospital after 5 o'clock in the evening, it's going to be all lit up. So blood, we need blood. We'll take it. And the blood is being given up north of the hospital. We call our 2600 thing. It's where our P's Rehab's at and the foundation's at. So encourage folks to sign up for the blood drive. Oh, parking. Yeah. How about the parking situation, Jay?
Well, I'm having at Lynn Boulevard, my front parking lot is being fixed right now. People are in the back parking, but at the hospital, I know it's also problematic.
Got a lot of parking going on here. So southwest entrance is where we want our patients to use. That area is where we want them to park if they need to go when they go into the hospital. So just want folks to know that. And want to wish you all a happy Thanksgiving and Merry Christmas and Happy New Year, as I won't be getting to talk with everyone in December. So,
and CGH is handing out the yearly turkey gift to all the employees, and that's today, right?
Yeah, I'm getting limbered up after our interview here, Jay, to get ready to hand those out. So,
no, it's a great service, and we appreciate it.
All right, and then we'll have Dr. Lucky next in January to talk about all things rashy. So, okay, we have to break out some slides for that one, I think. So,
that'd be fun.
Okay. Well, hey, Jay, great to have you, and thanks for all you do.
Thank you for letting me talk about hospice. It's something that I'll talk about every hospice awareness in November if we need to put it on the calendar. But
let's book it.
I'll be happy to meet with you whenever you want.
Sounds good. Thank you. All right, I'm going to sign out. I think my time's up, but great to thank you for those who watched, and please feel free to share this with your friends and family who might find this helpful. Until January, thank you for watching.